colleagues. My topic is a short summary of radiation oncology in the modern cancer therapy. I divided my talk into three main sections. First, I would like to talk about the role of radiation oncology in the complex approach of cancer therapy. And then in the two remaining parts, some words about the evolution of radiotherapy and image guidance role in modern radiotherapy. So in Hungary, now we have 75,000 patients newly diagnosed with cancer yearly. And as we discussed, the numbers are growing. So in the next decade, we're expecting approximately 100,000 new patients. With a really conservative approach in complex cancer therapy approaches, at least 55 to 60% of cancer patients will have to have radiation therapy during their treatments. And with the existing patients, now we can say that 25-30% of patients will need repeated radiation therapy during the treatments. So based on these facts, we would need at least 40,000 radiation therapy in Hungary. And if you look at this is a national database, that in the recent years, with the growing numbers, but there's always also some lack of radiation therapies in our system. Of course, the effect of COVID will be studied in the next years, so we are really waiting for this new data. In brief, the complex therapy of cancer in a modern setting is a strictly evidence-based, protocolized, multidisciplinary process. And in Hungary and in all developed oncological system, the decision is based on the multidisciplinary board decision. We call it OncoTeam in Hungary. And in these tumor boards, all the diagnostical clinical contributors must be there with the appropriate imaging, clinical and histological information of the patient. In our country from 2012, it has their low background, so the OncoTeam rule came out in 2012. Of course, in this board meetings, we make a decision on the possible treatments, can be systematic and local treatments. The systematic can be chemo, immune, hormone, or biological, alone or mixed. And the local treatments can be surgery, radiation oncology, and invasive radiology too. So radiation therapy can be used alone. We call it only radiation. It's quite rare in the clinical cases when the patient can be treated only using radiation oncology. The other situation where there is need for other approaches, but the patient is not available or not able to get any other treatments. Much more frequent approach when we use these modalities together. It's to improve effectiveness. We can use it together with surgery, immunotherapy, chemotherapy, immunotherapy, or both. So based on the combination, we can make groups based on the timing approach. So based on the timing, there is neoadjuvancy, adjuvancy, and intraoperative with surgical procedures. Okay, and based on the indications where the treatment goes, we can make groups with combined and single procedures on definitive, palliative, and induction settings too. The main types of radiotherapy, we make three big groups. So isotope therapy is relatively rare, but it's really interesting, and in the next future years will be on high attention, where some type of radioiodide agent connected to selective molecules are delivered for the patients. So there's a high growing interest in theranostic treatments. The second type is the brachytherapy, where some type of isotope is used for treating patients. We can divide them based on the dose rate of the treatments. The most common is the high dose rate after loaders, but also there is low dose rate, medium rate, and post dose rate after low dose too. If we want to make some organization in bright therapy types based on insertion type, there is intracavital, mostly gene indications. The other is more invasive, the interstitial bright therapy in breast, prostate, and head neck indications. There is surface for skin cancers, intraluminar and intravascular too. The most common type of radiotherapy is the teletherapy. LINAC-based, old cobalt-based, orthovolt or kilovolt-based therapies, heavy ion therapies, proton and carbon. As I learned, you came from a proton center, years. We also have isotope-based external techniques with gamma knife, and there is some specialties, the tomo and cyber knife, and the future is the MR LINAC, which is also on the market too. Just briefly, indication and definitions. When we talking about curative or definitive radiotherapy, the treatment goal is to cure the patients. So in this setting, we use high doses with more developed techniques in delivery. The next type is the palliation, the palliative radiotherapy, where the treatment goal is not to cure because the patient stage is not fit for curing. We mostly use low conventional doses. We try to make it as short as possible, but there is a mark with the simple techniques in the recent years. The palliative setting also developed a lot, so the stereotactic therapy is also on the palliative settings. In neoadjuvation before surgery, we use it mostly with advanced techniques to prepare patients for surgery. And in adjuvancy after surgery, the goal is to reduce the possibility of local recurrences. Also, advanced techniques are used. Some examples that how wide range of indications we use. For neoadjuvancy, rectal, esophageal, uterus, cervix, brain metastasis, sarcomas. And here you can see that also in neoadjuvancy, we now use stereotactic settings too. The adjuvant settings are also really wide range, all type of lung cancer, breast cancers, melanoma, stomach, head, neck, prostate, CNS primary, CNS metastasis, and also gene tumors. So in definitive settings, everything. So anus, cervix, uterus, vulva, vaginal, all type of lung cancer, head, neck, prostate, bladder, primary, secondary, CNS, skin tumors, pancreas, testicular, esophageal, all of them with high developed combinations and high developed techniques. And with the palliations, of course, the most common indications, it's brain tumors, bone metastasis, brain metastasis. And as you see that what I mentioned, in the modern radiation oncology, the metastasis means not simple technique. So much more techniques now used in single dose radiosurgery or fractionation of the radiosurgery, even in brain and even in extracranial settings. Just briefly, we quite commonly combine our treatments with chemotherapy and other systematic therapies is because the high percent of radioresistance of tumor cells. The most common is the chemo radiotherapies. The most common, there are many types, sequential, synchronous, alternating type of chemoradiotherapy. The most common is concurrent chemoradiotherapy, where we combine the full dose of systematic agent and full dose of radiotherapy. And it's another point why we need the sophisticated techniques, because here the side effects are adding together. So that's why you want to prevent patients for side effect with the most beneficial effect of the treatment. Shortly, the radiation therapy evolution is, we can say, the most robust in the modern history of medicine. The first patient, he was a 2.5-year-old boy. His name was Isaac Gordon, with retinoblastoma with a single static field on the LINAC, and it was 62. In the 70s, we used monoenergy LINACs with single handmade blocks, and the revolution came with the CT invention and the CT came into our daily practice on the treatment planning. And from the 90s to the early 2000s, we moved to the intensity modulation from 2D. And to see the difference, it's a simple head neck patient with a 2-field cobalt setting. Here's the target I want to treat with the huge normal tissue involved in the field. And it's not an IMRT, it's not simple, but a 7-field 3D technique where the same cover can be reached, but the normal tissues can be avoided. And what's our most common indication is breast cancer. We started with static 2-field techniques with the 2D manual planning, with the 3D, with the first manual IMRTs, and now today with surface guidance we do volumetric art therapies on breast cancers. The goal is to cover the target with prevent as many normal tissue as possible. Just easy to understand, breast cancer patients is a long-term survival. So we have to have as many positive effect on side effects as possible. In the modern radiation oncology, we use image guidance, we use IMRT, we use radiosurgery. AI is on the everyday use on contouring, on planning. We use radiobiologically based calculation models for dose planning, and we use MR-Linux and hybrid machine. Some examples on a normal 3D compared to the VMAT in the pelvic. You can see the difference in the bladder and the bowel doses. Also, the difference between 3D and proton. It's a 3D plan for a supraclavicle plan. So I can see it's really easy to understand the difference between the techniques. And here is the 3D versus the VMAT on breast. You can see the lung doses can be reduced dramatically. And finally, some examples of what we use, how we evaluated, and what's on the daily practice today. So now we know that there's really much motion on the target, on the patient, and of course we have the technical possibilities to prevent them. If you want to see movement, if you want to see the target, you have to visualize it. First generation Linux, you use your eyes. The second generation, we started to use MV-based portal imaging techniques. In the third generation Linux, inbuilt portal imagers, they called EPID, started to be in use, with improving image quality, but not so good. And now we got on the first generation Linux, the early fourth generation with the in-room CT, and the most common is the cone-beam CTs on the Linux. And on the state-of-art Linux, beside the cone-beam CTs, they have the 4D CT capabilities, so they can detect the movement, the tumor on the table. And on the fifth generation, the MR-Linux, there is a quite new approaches, which gives the opportunity real art, the real adoption. There is some additional techniques, the X-ray based tools, they call it exact track. There is motion following techniques in BrainLab. There is a Calypso system in Varian where there's a small radio transducer put on the patient and it can be followed. There is active breath hold techniques, not so common, which is approaching and in the recent decades came in real practice in the surface tracking and surface guidance. First, the really first ones used some models on the patient's chest to detect on the laser system. The CyberKnife system uses X-ray monitoring system. And tomorrow you will see in the last 10 years it developed the state-of-art SGRT systems. And adaptive radiotherapy, which is the present or the future, where we try to adapt our treatment fields, treatment plan, maybe day by day. This is the real adaptation. with many technical requirements. I think we don't have time for it now. And if we look at the future, in our view, the MR is on the focus, and it's really easy to understand why. With an MR Linux system, if you compare it to a really high quality Combim CT system, the difference I don't want to shortly. That's all. Thank you for your attention.